Hi, everybody. Thanks so much for joining us today. It's our first CRISM Addiction Rounds, and I'm happy to be your moderator. I'm Mohit Singh. I'm an addiction psychiatrist based in Edmonton, and I just have a little bit of housekeeping to go through before I turn it over to our speaker today. Just so you know, the webinar is being recorded and it'll be posted on CRISMPrairies.ca website, so you can access it there. And I also wanted to open the session today with a territorial acknowledgement. So the Canadian Research Initiative in Substance Matters has members from all across Turtle Island, the land also known as Canada. And we acknowledge that Indigenous peoples are the traditional guardians of this land and respect the sovereignty, lands, histories, languages, knowledge systems, and cultures of First Nations, Métis, and Inuit nations. Ongoing criminalization, discrimination, and institutionalization of people who use drugs disproportionately harms Indigenous people. And as such, we commit to ensuring this series is anti-racist, anti-colonial, and serves as one way to dismantle colonial structures that contribute to ongoing oppression. Thank you. And if you have questions during the sessions today, please use the Q&A feature to send those questions. And if you could send it to the hosts and panelists section tab, that would be great. You can send those at any point during the session, and the last 15 minutes will be reserved for questions from the audience and discussion that way. And also just a quick reminder that you'll get an evaluation by email after the session. So if you could complete that, it also lets you request a certificate for your attendance. And then without further ado, I'd like to introduce our speaker today, Dr. Elaine Hyshka, who's an associate professor and Canada Research Chair in Health Systems Innovation at the University of Alberta's School of Public Health, as well as scientific director of the Inner City Health and Wellness Program. Her program of health systems and services research is focused on advancing a public health approach to substance use in Canada. She works closely with service providers, health authorities, people with lived experience of substance use, and all levels of government to identify, evaluate, and scale systems innovations for improving health outcomes and advancing health equity. Elaine, we're really excited to have you, and I'll turn it over to you. Thanks.
Thanks so much, Mo. It's really an honor to start off this new series, and I'm so excited to see such an interest in learning more about the science around substance use and addiction, and to see the Prairies leading this series. So thank you, everyone, for making time to attend today. So thanks, Dr. Singh, for making the land acknowledgement, but I did just want to take time to note as well that, I'm coming to you today from Edmonton. I live and work on Treaty 6 territory and homeland of the Métis. And I think that anytime we talk about drug poisoning or harm reduction, we really need to acknowledge the contributions of colonial violence and land dispossession to the current epidemic, and the disproportionate impact of drug prohibition on Indigenous peoples in Canada. Ameliorating these harms requires a commitment to honoring the Truth and Reconciliation Commission of Canada's calls to action and supporting the human rights and health-based approaches to substance use. So my disclosures are all primarily related to research funding. I've received peer-reviewed research funding from CIHR and the Canada Foundation for Innovation, as well as a number of different grants, contracts, and awards from Health Canada, Canadian Public Health Association, and other government and non-governmental organizations. I previously served as the co-chair of I currently serve as the co-chair of the Institute Advisory Board for the Institute of Population Public Health at CIHR. I'm a principal applicant for the CRISM Prairie node, and I was previously co-chair of the Health Canada's Expert Advisory Group on Safer Supply and co-chair of the Royal Society of Canada's Harm Reduction Working Group in the context of their COVID-19 task force. I have no industry affiliations or any kind of private sector funding to disclose. Okay, so I've been conducting academic research on supervised consumption sites since 2012. And most recently I led CRISM's YSCS project, which was a national multi-method study collecting administrative, survey, and qualitative data with federally authorized supervised conception services. And this also entailed leading the creation of CRISM's first national guidance on implementing supervised conception services in Canada. So if you're curious to see that guidance or to learn more about our YSCS project, you can go to yscs.ca for some of the findings of our research, as well as that guidance document. So today I'm going to focus on supervised conception services and kind of give an update as to where we are now. So to start, I'll just review the epidemiology of the drug poisoning crisis with an eye to emphasizing why supervised conception services are an important component of our public health response. And then I'll discuss what are supervised conception services, give a bit of an overview of the state of them in Canada, go into some of the scientific evidence, and then I'll discuss the current challenges and future research directions. So Canada is currently, as we all know, experiencing an unprecedented drug poisoning crisis. And we really need to have a good handle on the epi of this crisis to appreciate why we need a public health response and why that has to include harm reduction, like supervised conception services. So since 2016, over 50,000 Canadians have died from opioid poisoning. And in 2024, on average, 21 Canadians died every day from an opioid-related overdose. In Alberta, we've been disproportionately impacted by this crisis, and we've lost over 10,000 Albertans since 2016 to opioid poisoning deaths. So why have we seen such an escalation in mortality over the past decade? It's important to note that what's driving this significant increase is not actually an increase in the number of people that are living with substance use disorder or struggling with drug use. So the data in this area are limited, but what we do have indicates that the prevalence of drug use disorders has been static over the past decade, or at least between 2012 and 2022. So it's not actually that more people are starting to use drugs and develop drug use disorder. What has changed is actually the illegal drug supply. And so there has been a fundamental shift away from, especially in Alberta, what was primarily diverted prescription opioids that were being sold on the illegal market and accessed, and used illegally. The market has shifted from that to illegally produced non-pharmaceutical synthetic opioids like fentanyl. And that is really what's driving this unprecedented drug poisoning crisis that we're facing today. The illegal drug supply has become so volatile that the potency and the toxicity of illegal drugs varies from batch to batch and even dose to dose. So as a result, it's extremely difficult for people who use drugs to know exactly what they're purchasing or to accurately predict the potency of the drug they're consuming. And this places people that are using illegal drugs at a very high risk of overdose or drug poisoning. And this data on the screen is just showing back in 2011, I remember that we were very concerned about drug poisonings. And, this is kind of the era of the do no harm efforts nationally. Everybody was talking about this as an emerging issue. And you can see that we had actually less than 100 overdose deaths in Alberta that year. As we saw the onset of clandestinely produced synthetic opioids starting in 2012 to 2013 in Alberta, you can just see that the numbers of deaths significantly escalated. And that really has been what's been driving mortality here and in other parts of the country. It's also important to note that most drug poisoning deaths involve other substances. So even though we talk about an opioid crisis often or opioid poisoning, we really can't get a handle on this topic or this crisis without recognizing that most people who use drugs are polysubstance using. And in particular, we've observed over the past decade a huge increase in the amount of people that are using stimulants as well as opioids. And so stimulant co-use has increased in Alberta and elsewhere. And this slide just shows you the latest data from 2024, which is the last complete year we have in Alberta, which shows that 65% of opioid-related deaths also involve methamphetamine. And that's increased from 23% in 2016, for context. So I would be remiss if I didn't point out that the impacts of the drug poisoning epidemic are not equitably distributed across the population. Males aged 30 to 44 are the group that account for the most drug poisoning deaths in Alberta. And we know from reviews of medical examiner records that most people who die of drug poisoning were using alone in some capacity when they died. It's also important to recognize that the substantial drug poisoning mortality burden on First Nations people in Alberta. The rate of fatal opioid poisoning for First Nations people is 8 times higher than non-First Nations people here. And that reflects the impacts of colonial violence and dispossession, anti-Indigenous racism, discrimination, and multi-generational trauma. And this disparity is so severe that it contributed to an 8-year decline in life expectancy for First Nations people in Alberta between 2019 and 2023. And the life expectancy gap between First Nations people and non-First Nations people in our province is now 19 years and the widest on record. So it really speaks to how important this topic is and how critical it is from a health equity perspective that we get on top of drug poisoning mortality and use all the tools we have to try to reduce rates of drug poisoning deaths, specifically for First Nations people in Alberta, but for all Albertans as well. Another trend to note is that the location of opioid poisoning deaths in Alberta has been shifting over time. And that most recently in Q1 of 2025, which is, the dead of winter here, a full almost 30% of deaths in Alberta occurred in outside locations or in public places. So people who use drugs in public often do so because they lack stable housing, and they're at an increased risk of drug poisoning if you're using drugs in public. And so it speaks to the need to address, in particular, the subpopulation of people who use drugs that use in public as a priority group for drug poisoning prevention efforts. So I hope these slides have really emphasized to you just what a substantial public health crisis drug poisoning is, and really also underline that the most proximal determinant of the current crisis is the toxicity and volatility of illegal drugs, not an increase in the number of people needing treatment for drug use disorders. And this means that treatment alone is unlikely to achieve sustained reductions in morbidity and mortality across the population. Using alone and in public are major risk factors for drug poisoning death. So supervised consumption services are one critical component of an evidence-informed public health response to drug poisoning. Because they support people who would otherwise use in public and or alone and engage anyone at risk of drug poisoning, irrespective of whether they are interested in seeking abstinence from drugs or needing addiction treatment. So if you're unfamiliar with supervised consumption services, a typical visit to such a site includes checking in with someone at the front to tell them some basic information about yourself as well as the drugs you plan to use. Waiting area, often these services can be oversubscribed, so people may have to spend some time waiting before they can access the consumption room, where they're able to access sterile injection supplies and consume drugs and be monitored for safety. And then as well a post-consumption area. And so in both of the consumption room and sometimes in the post-consumption area, if it has one, there's a huge emphasis on engaging with people and trying to support them and identify what needs they have and trying to meet those needs. But most critically, supervised consumption services provide a safe and clean environment for people to consume illegal drugs and to receive emergency medical care in the event of a drug poisoning. In addition to providing sterile drug use equipment, most services provide access to other types of care, such as wound care or other healthcare services, facilitated access to substance use treatment or opioid agonist treatment, counseling, income and housing support, and other connections. So there's a range of supervised consumption services that operate across 18 countries globally, and the main categories include standalone facilities, so fixed sites that are in one building that's specific for supervised consumption services, mobile facilities, which can be vans or buses that move around or are stationary but mobile. And integrated. So integrated services are services that are embedded in other kinds of facilities. So most commonly, we find integrated services within housing facilities, as well as increasingly in hospitals. So as of February 2025, there are 38 federally exempted supervised consumption services operating in Canada across 5 provinces. 40 overdose prevention sites. There's also around 40 overdose prevention sites also operating. And while there are legal differences in how OPS are authorized in Canada, for all intents and purposes, overdose prevention sites are the same as supervised consumption services. In Alberta, we have 5 supervised consumption services and 2 overdose prevention sites. So the overdose prevention sites are in Lethbridge, as well as in the Drumheller Institution, which is a federal penitentiary. And these numbers have fluctuated with some sites opening and some sites closing, but have generally remained around stable since 2018. So Health Canada is the main body that authorizes supervised consumption services, at least federally. Some provinces do also have their own provincial approval processes, including Alberta. But because they are authorizing SCS federally, they also require that sites report back a number of different data elements. And so I'm going to show you some statistics now that are just the aggregated data that Health Canada collects from SCS operators and then publishes on their website. So between March 2020 and February 2025, there were over 3 million supervised consumption visits in Canada. And within these visits, 48,152 non-fatal drug poisoning events were recorded and 0 fatal drug poisoning deaths. So supervised consumption services in Canada provide wound care, primary care, food and shelter, testing for sexually transmitted and bloodborne infections, and mental health care. During the same period, we know that there was close to 1 million services provided on site, which included over 170,000 referrals made to services within the embedded facility. So, for example, if a SCS is in a community health center, making connections to other parts of the health center for SCS clients. And an additional 70,143 referrals made to services that are located off-site or not in the vicinity of the supervised consumption site. So now that you have a sense of supervised consumption services in Canada and how many there are and where they're operating, I'm just going to go into some of the evidence on these services. So SCS are fairly widespread in Canada, and as they've grown in prevalence, there's been opportunities to do research on these services. So I'll draw both on Canadian research and also international research where relevant. So first, important to note that there's a huge body of literature that has addressed supervised consumption sites, including multiple systematic reviews. And these reviews look at both the health and social impacts of them internationally. So first, let's go over some of the outcomes of people that are accessing these services. So research has demonstrated that supervised consumption services engage a particularly vulnerable subpopulation of people who use drugs, including those who are at highest risk of negative outcomes. This includes people who are homeless or unstably housed and those who inject in public. Among a cohort of people who inject drugs in Vancouver, the people most likely to access an SCS were over 30 years old, injected drugs in public, were unstably housed, injected heroin daily, and had recently experienced drug poisoning. So these data are older, from 2005, but we know from looking at experiences at other sites across the country that really supervised consumption services are serving a subpopulation of people that are particularly vulnerable and often are unhoused or don't have access to safe and sterile environments to be able to use substances. So we do have some high quality observational studies that have demonstrated that there are significantly fewer drug poisoning deaths in the neighborhoods surrounding supervised consumption services following implementation. So for example, this is a recent study from Toronto an ecological study and spatial analysis that looked at the impact of the implementation of 9 different services in that city. And the authors found that the drug poisoning mortality rate went down by 67% in neighborhoods with an SCS within 500 meters, but they did not observe any significant changes in neighborhoods without an SCS during the implementation period or the study period. And so this decrease was significant, though slightly weaker as well, in neighborhoods with an SCS located as far as 5 kilometers away. So to account for differences in neighborhood factors, such as substance use related services and sociodemographics, they performed geographical weighted regression analysis and found that having an SCS nearby was associated with a lower number of drug poisoning deaths in the neighborhoods, irrespective of other factors. So in addition to reducing the risk of mortality for people that are accessing these services, which appears to be a neighborhood level effect, supervised consumption services are also associated with other improved health outcomes. This includes research that has shown reduced risk of all-cause mortality for frequent attenders of supervised consumption services in Vancouver. Research showing reduced hospital transfers following overdose in some settings, and also research documenting socio-emotional benefits. So qualitative research has highlighted that there are both emotional and social benefits of supervised consumption services, and the people that access them report that they foster a sense of safety, reduce stigma, enhance feelings of self-worth, and promote community connection. Supervised consumption services have also been shown to promote safer injection practices and reduce the risk of infectious disease transmission. So multiple studies have looked at this question, including this one here from Vancouver, which showed that the services reduce high-risk drug use behaviors associated with infectious disease transmission, including reusing or sharing syringes, rushed injection, and outdoor injecting. So this is data from a random effects meta-analysis model of studies from Canada and Spain, and they found that people who inject drugs who access SCS are 69% less likely to share syringes compared to those who do not. Supervised consumption services also facilitate access to other health and social services, and really play a vital role in connecting vulnerable people who use drugs to the broader healthcare system. The majority of supervised consumption clients engage with wraparound supports available on site at SCS or through referrals. SCS facilitate access to nursing and hospital care, hepatitis C testing, vaccination and treatment, as well as housing supports. So this has all been documented in prior studies. And there's also multiple studies that demonstrate people who access SCS regularly are significantly more likely to initiate treatment compared to those who access supervised consumption services only occasionally. So illustrated on this slide is a study from Catalonia, Spain, which found that frequent SCS users had more than double the odds of accessing treatment compared to those with limited or no SCS engagement. So I think it's hard to contest that there are health benefits related to supervised consumption services, and that there's been a wide array of benefits that have been documented in the context of these services. But we do know that critics of supervised consumption services frequently argue that even if they have benefits for people who use drugs, they come at a cost or of negative impacts to communities. So of course, when we're evaluating this as a public health intervention, we're sensitive to that critique. And there has been a number of studies published in the research that have focused on evaluating broader community outcomes related to supervised consumption services. So the first kind of area of work in this, looking at broader community outcomes, is looking at impacts on public injecting and needle debris. So there is growing evidence to show that supervised consumption services have little to no impact on public disorder outcomes. So the figure shown here was presented at the International Conference on Health and Hepatitis and Substance Users, and demonstrated that among people experiencing homelessness in Toronto, recent SCS access was associated with a 50% decrease in public injecting. We've also seen research from Vancouver and Sydney that have found that supervised consumption services led to fewer instances of public injection and discarded syringes, independent of factors like police presence and weather. Likewise, in Barcelona, the opening of an SCS was associated with a significant decline in publicly discarded syringes collected by local community services. And most recently, an observational study based out of Boston found a significant, that was a 28% decline in oversedated people following the opening of a supervised consumption service there, or a post-consumption service. So these services are unlikely to increase disorder in communities. Likely, when there are complaints about disorder, it's pre-existing disorder that has been there, because people are already using drugs in those spaces. And in some instances, there's data to show that they do contribute to improved community outcomes surrounding the services. So what about outcomes on neighborhood crime? So across multiple sites and settings, supervised consumption services are associated with improving or having no impact on crime, such as theft, robberies, assault, or homicide. Researchers from Toronto conducted an interrupted time series analysis of data looking at 9 years of police reported crime. And they compared changes in crime rates in downtown neighborhoods that did and did not implement supervised consumption services in the period prior to and after the sites were implemented. So when they looked at crime levels overall, there was no statistically significant change in crime rates after the implementation of supervised consumption services. Multiple studies have also evaluated police recorded crime trends in Vancouver, Sydney, and an undisclosed US city, and found that crime was stable following the opening of an SCS, with the exception of Vancouver, where there were sustained decreases in violent and property crime observed. So in addition to not contributing to increased neighborhood crime, supervised consumption services have been found to be generally cost saving. Multiple peer-reviewed studies highlight significant cost savings associated with the services, with estimated reductions in HIV infections, public health costs, and emergency services burden. A recent peer-reviewed cost analysis study from Calgary determined that each overdose managed on site at the Sheldon Schumer Center in Calgary produces approximately $1,600 in savings to Alberta's health system. So overall, published systematic reviews of this literature report that supervised consumption services utilization is associated with positive outcomes and no real evidence of negative individual or neighborhood impacts. While the literature includes a variety of robust observational designs and some quasi-experimental studies, increasing the latter could increase confidence in these interventions overall. Some critics have pointed to a lack of RCTs, or randomized controlled trials, as one reason not to implement or expand supervised consumption services. But randomizing supervised consumption service users or sites is practically impossible, as a highly localized and complex public health intervention serving a heterogeneous target population is not particularly amenable to RCT evaluation. SCS serve a unique population of people and are one of the only tools we have for preventing drug poisoning deaths. And they remain a critical component of the public health response, which should be scaled up and adapted to continue to meet population needs. So that's kind of the overview of where we're at in Canada with supervised consumption services and what some of the science is saying, including some more recent science that's come out of Canadian cities. I am now going to obviously acknowledge that there are current challenges associated with the implementation of the services and discuss some of those challenges, and then conclude with just an overview of where I think supervised consumption services research should head in the future. So anybody that works with people who use drugs on this webinar is aware that there has been a significant transition to smoking over the past 5 or more years. And one clear gap with regards to supervised consumption services is that most of them, including overdose prevention sites, do not accommodate smoking or supervised inhalation. And so this is obviously very problematic. And just to give you a sense of that, we just did this research in 2023. We did a big survey of 500 people who are using drugs in Edmonton's inner city, and only 36% of the people that we recruited into the survey reported that they were injecting drugs. So the vast majority were using drugs by inhalation, like smoking, but there are no sites in Alberta that accommodate supervised inhalation. And across the country, there, at least especially amongst federally authorized SCS, but also amongst OPS, accommodating inhalation is uncommon. I also think it's important to note that the transition away from injecting in Alberta is likely one of the reasons that we haven't seen a recovery of SCS utilization rates since, because they remain basically below pre-pandemic levels here. Closure of the province's only supervised inhalation site in August 2020 also led to a substantial reduction in SCS visits in Lethbridge. So between 2018 and 2020, or yeah, it would have been 2018, Lethbridge operated a large supervised consumption service that did accommodate inhalation. And because it accommodated inhalation, and probably for other reasons as well, it was seen as one of the busiest services in North America. But there was a policy change in August of 2020, and that service was closed and replaced with a small mobile facility that only supervises injection and does not supervise inhalation. Now, not accommodating inhalation is problematic because there is emerging data to suggest that pipe sharing, so when people consume opioids, they often share implements like smoking implements such as pipes, and that pipe sharing may actually be an independent hazard for drug poisoning. So this is a picture from a slide from a study that was done by Dan Ticciarone and his colleagues in San Francisco, and they documented actually the potential for the resin that builds up on equipment when people are smoking fentanyl. If that equipment is shared with someone that has a lower tolerance to opioids or doesn't use opioids, is potentially using it to smoke stimulants, that it could be potentially an independent risk factor or hazard for drug poisoning because the resin would then result in opioid exposure for the person that's using the pipe, and that if they're not tolerant, could result in a drug poisoning. Another major challenge facing supervised consumption services and overdose prevention sites in Canada is ongoing political backlash against harm reduction. In the wake of the pandemic, many cities have been struggling with significant increases in the number of people who are living unhoused and an increased, as a result, an increased public concerns over visible drug use. Supervised consumption services are becoming a scapegoat, in my opinion, for governments that are unable or unwilling to ensure adequate access to housing and safe emergency shelter. And lack of supervised inhalation space is exacerbating the situation by driving increases in drug use in urban cores, visible drug use. And so, for example, because people who are smoking drugs cannot be accommodated within Alberta's supervised consumption services, we do see sometimes people choose to use drugs outside the services instead because they know that emergency medical aid is very close by. And that obviously contributes to public concerns about visible drug use because that drug use is happening on the street and not happening within the service. Also important to link the political backlash against harm reduction to a broader trend towards increasing right-wing populism, not just in Canada, but also globally. And as a result of these populist shifts, we've been seeing multiple governments and political parties calling for the closure of supervised consumption services. In Ontario, there was legislation passed that led to the closure of a number of sites, as well as we've recently seen the closure of the Red Deer overdose prevention site earlier this year, and a cancellation of plans to implement a service on the Edmonton South Side. More recently as well, if you're paying attention to the news, within Calgary's municipal election, there has been a lot of discussion about the future of the Sheldon Schumer site, and the province has continually alluded to the potential for that service to close later this year. So although the politics are becoming more challenging, progress towards supervised consumption services, the development of this intervention and the research around it is persisting. And in recent years, there has been a rapid increase in the implementation of these services internationally. And this includes expanding these services to new settings, like places in the United States, as well as to Latin America and Africa. In Canada, we have seen innovative service models continue to operate and present opportunities for future study. So some of the innovation within supervised consumption services models includes things like virtual or in-person spotting, harm reduction hubs in private homes, and episodic and virtual protocols that have been described, but their outcomes have yet to be evaluated. So episodic OPS includes is demonstrated by the BC CDC episodic OPS protocol, which was developed during the pandemic. And this essentially was a protocol that enabled healthcare providers that were working in general healthcare facilities to be able to provide episodic supervision to people that use drugs who are admitted to those facilities. So for example, if someone was admitted to a housing facility that didn't have an overdose prevention site, this protocol enabled support workers to be able to observe someone using substances within their dwelling and then to provide emergency medical aid in the event of a drug poisoning. So it just provides some flexibility and expands access to these services beyond conventional fixed site overdose prevention or supervised consumption sites. NORS is another example of a virtual safe consumption service that is gaining popularity, at least public recognition. We know that there is a number of people that call into NORS and other hotlines and are connected with a live operator. They then report what they're about to use, give information about where they are and how people's emergency services could gain access to them in the event of an overdose. And then they're basically virtually spotted by the operator until the operator can determine the person is safe. And these services are potentially a really beneficial model for reaching people that are outside of areas where supervised consumption services are available. So thinking about people living in more rural and remote settings, as well as people that are living in neighborhoods that are far from supervised consumption services. We also have seen, in addition to hotline type models, the implementation of cell phone apps that provide a similar function. We also have seen the development of virtual or in-person spotting that's been developed by people who use drugs and is typically peer-led. And so this would be something as simple as potentially connecting with your friend on FaceTime and spotting them. It's not a formal service, but you're there and you're watching to make sure that they're okay after they use. And so that has also been a critical strategy that's been employed by a number of people and seems to have become more common or prominent as a result of the pandemic when people were spending a lot more time alone. And then also this paper by Cola and Strike, just colleagues in Toronto, documented the establishment of harm reduction hubs in private homes. And so this was spearheaded by an agency that was supporting outreach teams and outreach workers. And essentially the idea would be that an outreach worker was supported to invite people, if they lived in an apartment, for example, to come to their residence and then provide access to sterile supplies and also provide training in first aid and naloxone use, just to provide a safer environment for people that would otherwise be using alone in their own apartments. And so this is also potentially another strategy where we could expand access to supervised consumption services, leveraging very strong informal networks amongst people who use drugs and supporting already the innovation that's happening within the drug using community. It's also important to note that we've seen these services expand to new facilities, including within prisons or carceral settings. So the Corrections Canada does operate 2 overdose prevention sites right now. One's in Drumheller and the other's in the Maritimes. We've also seen these services implemented in housing-based facilities, so supportive housing, for example, or more like SRO type environments. And then more recently, we have seen the implementation of supervised consumption services into hospitals. And so the Royal Alex in Edmonton is a good example of that. But we also have other examples in Vancouver as well as Toronto. Another challenge, and I think an important area for future research, is that we have seen a trend towards accommodating more drug smoking within SCS outside of Canada, but unfortunately the research has yet to kind of catch up to documenting that, and we don't have great data on outcomes associated with supervising inhalation. I think that if we were to recognize the trends around drug utilization in Canada and enable supervised consumption services to supervise inhalation and not just injection, that would give us a really important opportunity to study some of those outcomes and facilitate more research. I think it would also contribute to reductions in visible drug use, because we do know that a lot of people are smoking drugs in public spaces. And historically, data has shown that people who use drugs outside are typically willing, even those who use by inhalation, to go to a site to use instead of smoking in public. And this is a picture of one of the few sites we have that supports inhalation in Canada, which is at Prairie Harm Reduction in Saskatoon. And I'll just note that this organization has been, in my opinion, heroically operating the service without any government funding for multiple years. And I just want to acknowledge the efforts of the staff there, because it's very hard. They work with very little resources, and Saskatoon in particular this year has been very hard hit with drug poisoning. Drug poisoning is related to carfentanil, as well as Edmonton. So some of the key priorities for future directions around supervised consumption sites are more quasi-experimental and comparative research to strengthen our understanding of the benefits and limits of the services. And this should be across models. So a lot of the research to date has focused on fixed sites, but we could have stronger evidence and better evaluations of different kinds of models, especially some of these more novel models like spotting or virtual services. We need implementation science to optimize service models. So not just evaluating outcomes, but also understanding what are the core components of these interventions that are really having the most significant impacts, and how can we best address the needs, which are ever evolving, of people who use drugs in terms of really, having the best kind of ROI for our investments, and also ensuring the highest quality care for people that are at extreme risk of morbidity and mortality. I think there are opportunities to integrate prescribed alternatives to unregulated drugs within supervised consumption services. As I highlighted at the start, the most proximal determinant of drug poisoning deaths is the volatility of illegal drugs. We are increasingly hearing concerns about novel molecules in circulation that are not only increasing the risk of fatalities, but also making it a lot harder to treat opioid use disorder, because people are developing codependence on a whole host of novel molecules that we don't always have the best evidence in terms of how to support them in withdrawing from those substances, and also managing cravings and things like that associated with them. There's also opportunities to integrate, we also need to examine the impacts of SCS closures on people who use drugs and the broader community. As I mentioned, there has been a number of services that have closed recently, and I think it is really important as health researchers that we try our best to access data required to evaluate some of the impacts of these closures. It's a little, as someone that works in public health, it's a bit depressing that we have to kind of study the closure of these services when, I think the evidence is strong enough to support implementing them further. But either way, I think it's important that we document the impacts of these policy changes. And then I'll just end on this last note. So I know that there's been a lot of political backlash, especially in Alberta, but elsewhere, around supervised consumption services. But it's really important to note that after 8 years of experience with these sites, 1 in 2 Albertans still personally support them. And this has remained constant since 2020. So this is some public opinion data that we collected, or that was collected in 2024 by the Viewpoints Alberta survey by my colleague, Jared Wesley, who's a political scientist at U of A. And so what they found was that a plurality of Albertans support supervised consumption services. However, when you ask people what's your perspective? What proportion of the Alberta population supports supervised consumption services? They think it's only 1 in 5. So even though 1 in 2 support, when you ask them what the rest of the province is like, they say 1 in 5. So it's not just that we need to, address political backlash and try to take the temperature down on the politicization around harm reduction and drug poisoning, but we also kind of have to work to close this issue distortion that we're seeing, and have people understand and recognize that actually more people support harm reduction and supervised consumption sites than we might believe. So I think we need some research also to figure out how to do that effectively. And that is definitely a question for the social scientists in the audience. So progress on SCS in Canada has been remarkable over the past decade, but the recent barriers and the kind of slowdown of this progress is frustrating, especially for those of us working to reduce drug-related morbidity and mortality in our communities. But it is worth noting that Canadian drug policy historically cycles through eras of promise, hesitation, and retreat. and that progress towards health and rights-based approaches has never been linear. And though the politics are becoming more challenging here, progress towards SCS internationally persists. And I do think it's a bright spot to see that there are increasingly more countries that are implementing these services and recognizing the importance of researching them and contributing to the evidence base. And I do hope that we will continue to see novel models emerge and more research done. And, eventually, I think hopefully a swing back to that era where we are committed to implementing a whole range of tools that can reduce drug poisoning mortality. So I think I'll end it there and open it up for questions. Thank you very much.
Thank you so much, Dr. Hyshka. Elaine, that was great, like very comprehensive review and emerging evidence around SES and other novel harm reduction approaches. Really want to thank you for that presentation. And looks like we're getting a bunch of questions already. And feel free to type questions into the Q&A and I'll get to them the best I can for Dr. Hyshka. And just a reminder that the talk, I know a lot of people joined a bit late, but the talk is available on the CRISM Prairie's website, crismprairies.ca, and it's being recorded. So, Elaine, just a few questions in the chat already. I'll start with this one, and you were talking about the political tension that exists at times with SESs, and this question is a little bit about that. But the question is, although SES is a critical harm reduction approach to drug poisoning crisis and substance use, do you think it takes the government's and public's attention away from preventive approaches to substance use? Like, I guess, what are your thoughts on that? Because that often comes up when we're talking about SCSs.
Yeah, I mean, that's a good question. I think, I am a public health person and I really value prevention. And one of the biggest gaps in our response under any government since this crisis has started has been looking at upstream prevention of drug-related harm and drug use disorders. So I don't think it's just supervised consumption services that take away from that. I think in general, in Alberta and Canada, our electoral cycles really predispose governments to focus on short-term wins. And, implementing a supervised consumption service can be done very quickly, same as implementing new treatment beds, for example, or relatively quickly within that 4-year cycle, and can be, a tangible way to show progress. When we're implementing prevention programs that are really effective at reducing risk of drug-related harm later in life, those kinds of things take decades often to show, at least a decade to show, progress. So if we think about the determinants of drug-related harm among, and what predicts sort of developing issues, we know we have to be really supportive of children in the early years, like 1 through 6, prevent adverse childhood experiences. We also know that we need to develop strong peer norms related to kind of pro-social behavior and other forms of recreation and leisure. And we also have to do what we can to support families and strengthen parent and child attachment. And so investing in programs that do those things are really important. And in my opinion, critical, but they're expensive and they take a long time to show results. And so I think that's the real reason we don't see an investment in prevention. And I don't think it's fair to blame supervised consumption services or harm reduction. And if anything, I would say governments focus a lot on these services to distract from their unwillingness or inability to make progress in other parts of the public health response, including prevention.
Mm-hmm. That there's room for every intervention from prevention to harm reduction. And so I really appreciate that. And, another question we have here is you cited a few studies that differentiated between occasional SES users and frequent users. Like, how was that defined in those studies, if you could speak to that?
Yeah, I have to laugh at Dr. Rittenbach pinning me down on details here, but I think the study that I'm thinking of was defining it as accessing it at least once a week, but I'd have to go back there. But generally speaking, I would be around weekly versus someone that maybe goes once a month.
Okay.
There has been some, I will say too, there has been some research out of a couple papers that I was on out of Montreal that did kind of look at trends around use. And so those might be instructive if you're thinking about categorizing data that way.
Right. Okay. Thank you. And from Dr. Hodgins here, what do we know about who uses virtual SE services? So, you put up the NORS slide, for instance. Are they a different subgroup than people who use in-person sites? So another good question.
Yeah, that's a great question. And to be honest, I'm not as familiar with that literature as I am with like the fixed sites or the more conventional supervised correctional services. But I do believe that they are serving a population of people who are likely to be potentially, more stably housed or have, a safer place to use, as well as to be less likely to be living in an urban core or a central part of a city where there is access to supervised consumption. I
Right.
suspect that I would guess that maybe women are more likely to use these services compared to conventional supervised consumption services. But the good news is that we do have a group in Alberta led by Dr. Ghosh that is evaluating NORS. And I know they put out a number of different papers on both qualitative and quantitative metrics from NORS. And so I'd encourage people to check out that literature.
Yeah, thank you. I think it's just the beginning of, the use of technology in this space. So it's really interesting to study that. And another interesting question, and I was wondering about this as well because I'm a forensic psychiatrist also. And do you know how the two OPSs within the federal correctional facility sites operate? Are they also federally exempted? Curious to know if there's tension within the traditional enforcement views and within the in the incarceral system. So, yeah, I guess do you know anything about the data and how those sites operate, for instance, in Drumheller that you mentioned?
Yeah, I haven't visited the Drumheller OPS myself, but I have heard from colleagues that work in kind of hepatitis prevention in prisons around sort of like the protocol for overdose prevention sites. And from what they describe, it's quite rigid. So people have to kind of fill out a form and sign like basically declaration saying that they're using substances. And then there's a review of that form before they're allowed admission to the OPS. And then there's a number of different rules that kind of dictate when they can access it and what's the eligibility criteria. So from what I understand, it's a very high threshold service. So it's likely not reaching everybody within those settings. And some of the reason it is high threshold is because of pushback from unions in particular within those spaces who have opposed the implementation of them. Although I will say that I've seen a little bit of like data at conferences that talk to guards about them, and most generally have supported how they've been implemented. But then on the flip of that, we're hearing from people who use drugs and advocates of kind of like prisoner rights organizations that are saying that those services are not sufficiently accessible within the settings where they're implemented. So I think there's probably more implementation science that needs to happen to figure out how to balance, on the one hand, the need to maintain safety of workers, but also to ensure, access to services. And I do think there's real potential if they're implemented well, to reduce risks of drug poisoning deaths in the settings, as well as to reduce the risk of injuries by sharps and bloodborne the spread of bloodborne infections. And while it's novel in Canada, there are a number of other countries that do have services implemented in carceral settings. And so we can also learn from those international experiences.
Hmm. Yeah, that's really fascinating to me as, someone that works inside these types of facilities from time to time. And I think it's really important to be able to offer all the interventions, right? From Suboxone and Sublocade all the way down to SES. And
Yeah.
you're going to have people that need the interventions all along that spectrum.
And it's interesting too, because the reason we have overdose prevention sites is they were implemented after following litigation from a person in Ontario who contracted hepatitis C while in prison from injecting drugs. And so they sued the federal government in a charter challenge. And the federal government kind of, in an attempt to kind of like settle that case, offered to implement overdose prevention sites. And this was seen as by the federal government as a more desirable solution than what they were asking for, which was to distribute sterile supplies. So there is, I think, still like there's a lot of different policy context around these interventions, and there's a lot of different competing kind of uh, objectives with them. And so we need to really kind of think about what's the best way to prevent STI and BBP for people that are incarcerated, and as well as preventing drug poisoning deaths. And, the more we can do research in these spaces, I think
Mhm.
the better access we'll have to kind of, these different viewpoints and figure out ways to reconcile them.
Yeah, that's great. Thanks for that. And yeah, you put up one of your last slides was like perception of SESs, and I'd be curious to know what, correctional officers and others within the facility, perceive this as because, maybe there's a different perception than what we might assume.
Yeah, certainly what I've seen suggests that that's potentially the case. And there was one report, and I think it's public, that was or at least I've seen conference data from it, that was done by a researcher in Ottawa, who did get a contract to evaluate the site and did talk to people about their perspectives. So I think if you Google it, it might come up. I'm pretty sure it's public, but if not, they are working on collecting that evidence.
Thank you. And there's another question about maybe I missed this when you're talking, but did you mention something about novel molecules?
Molecules. Yeah, sorry, that's technical jargon. I apologize for that. I meant to say that we're seeing the illegal drug supply increasingly contaminated with a whole host of different substances like novel benzodiazepines.
Mhm.
So benzos are, things like Valium, but instead of being like pharmaceutical grade, these are clandestinely produced and then sold, and also often mixed with synthetic opioids. So that's one issue, is like this frequently contamination from benzodiazepines, but we're also seeing issues around xylazine, which is a veterinary anesthetic that people are using unknowingly, and it can lead to a whole host of negative health outcomes. So when I say novel molecules, I just mean that because we have the legal drug market is always innovating. People who are making profits in this market are always looking for ways to increase the impacts of their products and make more money. And so as a result, we're seeing all these new substances emerge that aren't, approved for use amongst human beings. They haven't been tested in laboratories. And the medical community, as well as the law enforcement community, are constantly like two steps behind this and trying to figure out what's circulating, what are the impacts of it, and how can we prevent it. And it's just kind of a vicious cycle.
Yeah, thank you. And just I guess my own version of this last question that's up here, but like and maybe I'm asking you to solve the political problem, Elaine, but like what's the best way forward to stop this from being a political issue? Because we know that both treatment and harm reduction approaches are equally important and need to be available. So, what are your thoughts on that, I guess?
Yeah, that's a good question. I mean, I wish I had the answer. I would implement it. I think for us, like, I think most people attending this webinar are people that are working in this area, probably from healthcare or from science and academia. I think, and I challenge myself to do this too, to really recognize the value of a comprehensive approach and to not give into this idea that harm reduction and substance use treatment are opposing. Like, everybody that works in the space knows that people can benefit from both, even often at the same time, even. And so to really do what we can to publicly resist that artificial division, where we're trying to see, we're seeing different actors try to divide us and say that, it's either harm reduction or treatment. No, it's and both and more. So I think that's one thing. I think talking with your friends and family about it is important too. Like, people do shape the opinions of their social circles. And so if you can share what you know about it and your experience with it, I think we also need to do a lot to empower the voices of lived experience, to support people who use drugs to talk about things publicly. It's very challenging for them to do that often because they face real stigma, discrimination, and backlash. But I think the more that people hear from those that have direct experience with these services, the harder it is to oppose them, because they really do recognize the life-saving benefits and the life-altering benefits. And while not everybody that uses drugs is going to want to go to a supervised consumption site or potentially benefit from it, it is a real core intervention for a subset of people that are particularly vulnerable. And so, yeah, trying to show the humanity behind these services, I think, is really important too. And then the last thing I'll say is, I think a lot of the opposition to supervised consumption services in the past few years, in particular in Canada and Alberta, is related to the fact that we've seen a dramatic increase in the number of people living unhoused in many communities, including in Edmonton, where I am. And I think, unfortunately, supervised consumption services are becoming a bit of a scapegoat for that. And I think we really need to be calling on governments and building coalitions with our colleagues in different areas, to address the housing crisis and to get more people into safe and stable shelter and to get them into permanent housing. Because I think the more that we can do that, the less visible drug use there will be, and the less kind of like visceral public backlash and perceived safety concerns we'll hear from communities.
Mhm. Yeah, thanks so much, Elaine. Really appreciate your thoughtfulness around that answer, and also just thank you for this talk in general. And I want to thank everybody for attending today as well. And Just a reminder, you'll be getting an email with a short survey. And also, if you'd like a certificate, you can request it through there. And just a plug for our second CRISM Addiction Rounds will be on October 8th, the webinar with Dr. Meldon Kahan, who is the director for the Medify guidelines and program. And so thank you so much for your time, and a big thanks again to Dr. Hyshka, and we'll see you next time.
Thank you.